Imagine a dark, textured mass tumbling quickly through the inferior vena cava, or IVC. The IVC is the large central vein that carries deoxygenated blood from the lower half of the body back to the heart. When a large clot enters this high-flow vessel, it poses a direct, immediate threat to the lungs. To intercept this threat, clinicians deploy an IVC filter. There are two absolute clinical indications for this procedure. The first is a proven pulmonary embolism, a sudden, life-threatening blockage in the lung arteries, in a patient who is already on adequate anticoagulation. The second is an active clot in the femoral or iliac veins when the patient has a strict contraindication to blood thinners. Operators choose from three categories of hardware. Permanent filters are designed to remain in the body for the patient's lifetime. Retrievable filters are designed to be removed, but can safely remain indefinitely without extraction. Temporary filters must be removed, utilizing a component that remains exteriorized outside the body to aid in retrieval. Regardless of the specific model or retrieval classification, all modern filters share one universal hardware baseline. They are engineered to be completely MRI compatible. Deploying an IVC filter requires an active calculation to balance clot interception against venous hemodynamics. The hardware must block incoming emboli without completely obstructing normal blood return. The prerequisite to any deployment is the pre-procedural angiogram. An angiogram is a medical imaging technique that uses injected contrast dye and X-rays to map the inside of blood vessels. The initial angiogram serves four distinct mandates. The first two mandates are confirming the overall patency of the IVC and documenting that the patient does not possess a duplicated IVC anatomy. This clinical flowchart maps the final two mandates of the initial angiogram. The operator must map the precise anatomical location of the renal veins and measure the exact diameter of the cava. That diameter measurement dictates hardware selection. According to the megacava sizing thresholds, standard conical filters are only viable for an IVC diameter measuring less than 28 millimeters. If the IVC exceeds 28 millimeters, the deployment algorithm requires a hardware shift. The operator must utilize a complex wire mesh device known as a bird's nest filter, which is viable up to 40 millimeters, or deploy bilateral filters directly into the iliac veins. Attempting a procedure without angiographically mapping and mathematically measuring the IVC guarantees hardware failure. Once the anatomical baseline is confirmed, the default deployment target for a standard filter is the infrarenal position, meaning just below the renal veins. Placing the conical apex of the filter exactly at the level of the renal veins leverages the high blood flow from the kidneys. This fast-moving flow theoretically aids in dissolving trapped clots while preventing renal vein thrombosis. Thrombosis is the formation of an obstructing blood clot inside a blood vessel. The practical interventional challenge is locating those renal veins on fluoroscopy. Often, the renal veins do not perfectly opacify or become visually solid with the injected contrast dye. When clear, unopacified blood from the renal veins pours into the dark contrast column of the IVC, it creates swirling mixing patterns. Interventionalists use this subtle steaming artifact to deduce the exact anatomical level. The center of these clear, swirling streams pinpoints the invisible side branches. Reading the visual artifact of steaming separates theoretical knowledge from real-world procedural success. The infrarenal default assumes standard anatomy and localized clotting. If an existing clot in the IVC already extends beyond the renal veins, the operator must position the filter above the clot's most cranial extension. Pregnancy triggers a mandatory exception. The expanding uterus creates mechanical compression on the lower vena cava, forcing the operator to shift deployment to a suprarenal position. If the patient has an existing clot located proximally within the renal or gonadal veins, the standard target fails. Placement must shift to a suprarenal position to establish a secure perimeter above the risk zone. The duplicated IVC anomaly requires a strict structural deviation. The protocol demands either bilateral deployment in both iliac veins or a single suprarenal placement, positioned above the point where the duplicated vessels bifurcate. This schematic shows a circumaortic left renal vein anomaly, where a left branch wraps around the aorta. The deployment target is below the lowest branch. Placing the filter any higher allows an ascending clot to bypass the hardware by detouring through the lower anomalous branch. Safe deployment requires anticipating anatomical deviations and actively outmaneuvering them with adapted hardware placement. Post-deployment complications range from benign visual artifacts to severe clinical emergencies. A tip malposition resting slightly below the renal vein is technically incorrect, but clinically minor. Caval wall perforation, but a single wire strut poking through the vessel wall is common and generally requires no intervention. Major perforations occur when an extended strut penetrates surrounding structures. Penetrations of the aorta, duodenum, ureter, or lumbar vessels are critical emergencies requiring immediate intervention. Hardware migration also triggers strict protocols. If the filter migrates superiorly within the cava, it must be snared and retrieved. If it migrates entirely into the heart, it mandates immediate open surgery. The overarching constraint on placing the device in the first place is device infection. Active bacteremia, which is the presence of circulating bacteria in the bloodstream, is a relative contraindication to deploying any foreign body filter. These devices exist within a physiological paradox. They successfully and predictably decrease the overall incidence of pulmonary embolisms. This visualization shows the hidden cost. While the risk of pulmonary embolism slopes downward, the localized risk of deep vein thrombosis rises sharply. Deep vein thrombosis is a clot that forms deep within the venous system, typically in the legs. The hardware solves an acute physiological crisis by introducing a new, long-term thrombotic risk. This ongoing localized risk necessitates strict removal protocols. The fundamental rule of filter dwell time dictates that the longer the device stays inside the body, the higher the likelihood of complete device thrombosis. Prior to any removal attempt, the operator must perform a dedicated pre-removal angiogram. The sole purpose of this imaging is to evaluate the total accumulated clot burden trapped within the filter basket. This diagram displays the strict quantitative threshold for removal. If the angiogram reveals a clot burden greater than 1 cubic centimeter inside the basket, the filter must remain in place. The inverse volumetric rule dictates that if the measured clot burden is less than 1 cubic centimeter, the filter is cleared for immediate removal. If an active clot larger than the threshold is caught inside the filter, the operator faces a strict procedural contraindication. The clot must first be chemically lysed, or dissolved with targeted medication, before removal can even be attempted. Physical retrieval requires specific tool interaction. Devices like the Gunther Tulip utilize a superior end hook that is engineered specifically for snare capture. The definitive standard for mechanical resistance governs the extraction. If pulling the snare meets physical resistance, the operator must assume the device has endothelialized, grown permanently into the vessel wall, and abort the retrieval. Filter removal is dictated entirely by strict volumetric thresholds and tissue integration, never by applying excessive physical force. Once a filter is successfully removed, a final angiographic run must be performed immediately. This confirms the structural integrity of the newly bare cava. This demonstrates the immediate rescue algorithm for a torn IVC. The operator must instantly deploy an angioplasty balloon with low-pressure insufflation to create internal tamponade. Insufflation is the expansion of the balloon with gas or fluid, and tamponade is the closure of a wound by applying direct pressure. If the balloon tamponade fails to stop the bleeding, the operator escalates the rescue effort. The immediate next step is deploying a covered stent graft directly over the rupture site to seal the defect. If the mechanical extraction caused a vessel wall injury or an internal dissection rather than a free rupture, the alternative complication protocol goes into effect. The treatment shifts entirely to systemic anticoagulation. IVC filter management requires an unbroken life cycle of precise anatomical mapping, rigid mathematical thresholds, and algorithmic bailout protocols. Safe operation demands an absolute respect for the vessel, from initial deployment to final retrieval.